Welcome back. I'm Tracy Mullen, and if you're following the podcast, you'll recognize today's guest, Dr. Kaitlin Dupuis. She's an Ontario physician and menopause expert who has spent over 15 years helping women thrive through hormonal change. Kaitlin joined us recently for an incredible conversation about navigating Ontario's healthcare system, and today she's back to tackle a new topic: hormones, aging, and skin health. Dr. Dupuis, thank you and welcome back.
Oh, I'm so happy to be back. It was a lot of fun.
Good. So first of all, can you define like perimenopause and menopause for me?
So a lot of people think that perimenopause and menopause are diagnoses that are made in lab work with hormone levels. And they're in fact not. They're both clinical diagnoses based on symptoms. So in terms of perimenopause, a lot of people think, oh, it's my hormones just starting to decline. But what's happening in perimenopause is that your ovaries, there's a fixed timeline on how many eggs you have when you're born.
Right.
And they've slowly, over the course of your life, all of those eggs have been released as you've had your period. So what's happening now is you are not ovulating as regularly because there's fewer egg supply left. And because you're not ovulating as regularly, the feedback to your brain saying, oh, there's actually, you ovulated, you have estrogen and progesterone hormones in the body, it's not there as much in the brain anymore. So your brain says, oh, well, you didn't ovulate, so maybe I should ovulate again. So in fact, in perimenopause, it's not just hormones being lower, it's fluctuation in hormones. So the general trend in perimenopause is that your estrogen could go really high, it could go really low, it could go really high, it could go really low. But overall, the trend is downwards. Over some people, it's 10 years. Mm-hmm. So those terrible symptoms that people are experiencing, the hot flashes, the brain fog, the irritability, the poor sleeping, it's actually the fluctuation of those hormones that's the issue. The number one way that you're going to know if you're in perimenopause is by cycle tracking. So I will say with a caveat, if you've never had regular monthly cycles, this is really difficult for you.
Right.
But if you've had a regular monthly cycle and all of a sudden your periods are now differing by up to 7 days later or like shorter or longer, and you have these other symptoms, you can be pretty sure that you're in perimenopause. The actual clinical definition of menopause, meaning you are done ovulating, you are officially in menopause, is that you've gone 12 calendar months with no period.
Okay. I actually got the slow burn first. Like my body was like a fire. To touch it, it was hot, but I actually couldn't feel it. That's how mine started, was the first 3 or 4 months. It was like my body was really hot to the touch. Yeah. And then all of a sudden I started getting hot flashes that were, I didn't think I'd get them, but they were terrible. Mm-hmm. I was sweating and throwing clothes on, throwing clothes off. I was dressing up, dressing down. It was crazy.
I hear what you're saying about how distressing this is. And I think, historically, I will say with women's health, we haven't had a lot of research focus on women's health. And a lot of the old medical terminology in regards to women's health is very closely linked with mental disorders. Right. So for example, like a uterus, the term is to have your uterus removed is hysterectomy, which is linked to the word hysteria. Mm-hmm. So this ties back to hot flashes in that this is almost something I think culturally, at least in Western culture, we kind of like, oh yeah, you're sweating, like you're having hot flashes, not that big of a deal. Like you're just sweaty and like maybe you're kind of over exaggerating. And, but really like hot flashes significantly disrupt the lives of women who are experiencing them. I would say first and foremost in terms of sleep. So most women will have hot flashes in their sleep, disrupting their sleep cycle. Once you've disrupted the sleep cycle, you now have a cascade of other hormones that are kicking in to royally mess up your day.
Right.
So the effect of hot flashes, we say it almost kind of jokingly, or at least we did, but now we really recognize this as a true medical symptom that is deserving of treatment.
Right. Well, I didn't get the irritability. I've never had that. So I'm lucky that way. I got the hot flashes and I also got the whoosh. So I just fall asleep and I'd get this whoosh and it would wake me up.
Yes.
And then I'd be up for hours.
Yes.
I could be sleeping 10 minutes.
Yes. So what happens, I'm going to nerd out for a second from a physiologic standpoint.
You
so
like every minute of this, you're loving it.
I'm loving, I just love sort of the talking about pathophysiology and hormones. But as your estrogen declines, it narrows the area in the brain called the hypothalamus that controls your temperature. It narrows the range of what is an acceptable temperature in your body. So particularly, we call it the thermoregulation zone. So by narrowing that, you experience more extremes. So a lot of women will say, well, actually, I go from hot flashes to freezing cold shivering. And it's just because that actual thermoregulatory zone in your hypothalamus has narrowed as a response to low estrogen. So it's a absolutely physiologic phenomenon that is
response
known, in menopause.
Well, I'm lucky because I feel like I'm on the other side now. I'm not getting nearly hot flashes. My sleep is way better.
Yeah.
Do you have anything anybody that's suffering right now with not being able to sleep, do you have any suggestions for them? Like, what can they do?
Yeah, so sleep is interesting because it's such a multifactorial problem. Anybody which is probably all of us, have had trouble sleeping at some point in our lives. We know that so many things affect sleep. So stress, hugely affects sleep, and that is likely through the cortisol system. So when you're stressed, your cortisol goes up, and that hormone is designed to keep you awake, and you get this burst of it when you're in a stressful situation so that you kind of have everything mobilized. Your blood glucose goes up in case you need to run away and, fight. And so that's great. It's a great system, but not really great at 11 o'clock when you need to wake up at 6 a.m. the next day. Like, you want that to be slowing down. So cortisol plays a huge role. And then also your neurotransmitters like serotonin, dopamine, these are all neurotransmitters in your brain. We know that estrogen and reproductive hormones, estrogen, progesterone, closely interplay with those. So if you're perimenopausal or menopausal, it's going to affect those levels. So sleep as well as mood. And then declining progesterone affects a system in your brain similar to the receptors. They're called GABA receptors. They also are activated when you drink alcohol. That's why a lot of people feel sleepy when they drink alcohol. But progesterone targets those receptors. So as your progesterone declines, your GABA receptors aren't being signaled, and so you become less sleepy. So that's why you can fall asleep and then you wake up and you're ready to go at 1 o'clock in the morning.
Right. I'm like 2 to 4:30, 5 o'clock, and then I'd fall asleep and I'd just get into a good sleep and it's time to get up.
Yes.
Yep. So do you think magnesium or melatonin or any of these things? Melatonin makes me really groggy the next day, so I can't take that. But magnesium seems to have helped me.
Yeah. So, sorry, going back to your original question of what do you do if you have sleep problems? So I would ask, when did your sleep problems start? If you've been a terrible sleeper since you were in your 20s, then and nothing's really changed, probably perimenopause or menopause is not affecting that. But if you've noticed your cycles changing, and they were previously regular every month, you'd get a period, and now maybe you're skipping a month, or they're coming 7 days late, or whatever it is, and you're now having trouble sleeping, it is almost certainly related to hormones. And so in order to repair your sleep, you need to replace those hormones that are lacking. Yes, you can put a Band-Aid on it of melatonin and sleeping pills that you'll become addicted to, and but you're not addressing the underlying issue.
Right. Yeah. So there's mood, there's sleep, there's weight gain. Let's talk about that, because it's one of the things that women just so are focused on, their weight. And when they get to menopause, we seem to get this little bit of weight more around our stomach.
Yeah.
Is that normal? Is it something that can be helped? What do we do?
Very normal.
Okay.
So estrogen does help with how fat is distributed within the body. And when you are lacking estrogen, adipose tissue or fat will preferentially deposit around the abdomen, the waist, hips, lower abdomen. A lot of what women report is that their daily habits they've used for years to maintain a healthy weight and have good energy, and so, eating a healthy, balanced diet and having regular exercise, that's just not doing the trick anymore. And they're like, I don't understand. I'm doing the exact same things and nothing's changing. And it's because the calories that you're taking in and the fat that you're depositing, which fat is healthy. We need fat in our body. It's just being deposited in different places, and places that, for us are A, not aesthetically pleasing, but B, also we know that central abdominal fat is associated with many negative outcomes like metabolic syndrome, diabetes, cardiac disease.
So it leads to more health complications later on.
Absolutely.
Trying to control it now is that why Ozempic and other drugs are so popular right now?
Yeah. I mean, I could have a whole episode with you about GLP-1s.
Maybe we'll have you back.
Okay. Would love it. GLP-1s, so much to say about them, but largely vilified in the media because our society, and this is my opinion, is that our society is very judgmental about anything to do with body weight. These drugs, in fact, they are so robustly studied because the data around them is so massive because 1 in 8 Americans takes a GLP-1. So we have now
1 in 8?
1 in 8. Wow. That number's probably even higher. I've heard 1 in 5.
Wow.
The data is so robust because we have millions and millions of people who now have 1 to 5 years experience on this medication. GLP-1s have actually been around for much longer than that, but in forms where they were used therapeutically has been, I would say, picked up in popularity in the last 10 years or so. When used appropriately at the right doses, they will change the landscape of diabetes and obesity medicine forever. I've been really, really impressed with what GLP-1s have done for my patients, especially menopausal patients.
Right.
Yeah.
So I guess weight loss is better than carrying the extra weight and leading to more chronic diseases later on. So being on Ozempic or some other drug would be better for somebody long-term in some cases.
In some cases,
Yeah, not
patient specific, like definitely not giving the blanket advice to go and
no,
go start.
don't run out and get some. No.
But because when it's used inappropriately, it can be very scary. But when used appropriately and under medical supervision, I have seen some incredible results, not just aesthetically. I'm not just talking about weight loss, but in terms of your metabolic profile, the data on preventing cardiac, kidney disease, dementia,
diabetes.
Diabetic is, I mean, our society as a whole is so resistant to our own insulin, probably because of the food that we eat and our inactivity.
Yeah.
So this, GLP-1s will be, they're here to stay. For sure.
Good to know. What about hormone therapy? What can you tell us about who should be on it and who shouldn't ever take hormone therapy? Yeah.
So we'll do a little history lesson with hormone therapy. And at this point, I think, menopause has really wonderfully had quite an explosion in the media and social media. We're paying a lot of attention to perimenopause and menopause, which is fantastic. So most people know about the Women's Health Initiative study that was done that related combined hormone therapy, which is referring to estrogen and progesterone, to an increased risk of breast cancer and bad cardiac outcomes in women. When the data, and so what happened was, like when I trained, that was 15 years ago, it was rare that we would put a menopausal or perimenopausal woman on hormone therapy. Very rare. I don't actually even remember prescribing it. It was sort of like the risks are too high, we're not going to do it. And in the last 10 years, we've looked at the data again and realized this data set was extremely cherry picked. So you had people who had been out of menopause for, on average, 15 years. So women about 65 years of age that were given combined hormone therapy. And the signal for increased breast cancer and cardiac disease, it didn't take into account the fact that these women are 15 years older than typically the women who are starting on hormone therapy. So by looking at that data, we saw the risks, while there, are much less than we thought, whereas the benefits in terms of so many things of being on menopause therapy, menopause hormone therapy, they were really undeniable. So just to name a few, but osteoporosis. So when you are not on estrogen, you will become osteoporotic, which increases the risk of fracture and serious fractures, spine fractures, hip fractures. And so we had to put women on other treatments that were not as effective. They still work, but not as effective as if they had just had hormone therapy at the time they were going through menopause. Cardiovascular outcomes, potentially dementia, reducing dementia. And then of course the the treatment of the actual bothersome symptoms like vasomotor symptoms or hot flashes, what we call them, and terrible genital symptoms, frequent UTIs, yeast infections, pain with sex, terrible symptoms, and the cognitive impact. So these poor women that we made suffer through these terrible symptoms.
Now we're getting some relief.
We're getting relief.
We can talk about the vagina if you want.
Oh, absolutely. I do every day. So more than
we can
happy.
talk about that. You recently helped me.
No,
It's like, you recently helped me with the dryness was terrible.
Yes.
Right.
So that, and I mean, the thing is a lot of people, it's embarrassing to talk about this, right? And
well, my daughter's a physician, but I didn't want to ask her, and now she even knows.
You're welcome. Yeah. So, I mean, I will say that in medical school and residency, we did not have a lot of training on menopause. I think we had a few days, to be honest with you, and there's a chapter in our book about it. But unless you have a side interest, your family physician is going to know sort of the textbook answers, which is usually okay. But in some cases is not, especially as there is emerging evidence. So what I'm finding is that a lot of people will come to me and say, well, I saw a physician who said I should never go on hormones because I would get breast cancer. Mm-hmm. Or I should never take vaginal estrogen because I'll be at risk of XYZ, when we know, and there's been a lot of advocacy, especially in the US, there's a black box label on vaginal estrogen saying like this will increase your risk of heart attack, stroke. And we know it's not systemically absorbed, meaning it's really only in the vagina that the action is working and it's not being absorbed into the bloodstream. So this is a safe intervention for almost every menopausal woman.
Right. Well, a lot of my friends just stopped having sex because it was so painful.
Yes.
They just didn't do it.
Yes.
And I'll tell you, it was like less than 2 weeks that made the difference
That
for
works.
me. Yeah. So
no,
high five.
You're welcome. But I mean, to be honest with you, menopause care, I love it because it is one area of medicine that is so satisfying. You can really dramatically change someone's quality of life with very few interventions, just by nerding out a bit on the physiology of it.
Yeah. Well, it's perfect. Yeah. I'm glad I mentioned it to you. I was at the appointment. I was like, I want to talk to you about something else.
Yes. Yeah.
It is embarrassing to talk about, but I think my women friends are sharing more now than ever before. And they can get a lot of the answers on, like you said, ChatGPT or Google or any of those places. They can go and get some of their answers, but it's like, who do I turn to talk to, right? So
there's a fantastic society that I'm a member of, and this is where I was credentialed. So if you're a healthcare practitioner, you have a particular interest in menopause, you can take a certifying course through the North American Menopause Society. And on the North American Menopause Society website, there's a little section when you go to the main page that says find a healthcare professional. Oh. You can actually look in the directory and search by country and province. And then you can search by type of healthcare profession. So if you want to see a naturopath or a physiotherapist or a physician, you can see who's in your city and you can search that. And then some of them, it'll indicate they need a referral to see them. Some of them don't need referrals.
You don't need
I don't need a
referral,
right? to see patients.
Right. And you're in Toronto. You're at the North Toronto Surgical Clinic where you see your patients for this. Okay.
Yeah. So patients can just contact our clinic by phone or email and I'll see them. So access is getting much, much better because it's a bit hit and miss. Like say you went into a walk-in clinic and said, oh, I want to talk about menopause hormone therapy. You may encounter somebody who, has a good background knowledge, but you may not. Just like if someone came to see me and said, oh, I want to talk about andropause, like men's menopause. I'd say, okay.
I've never even heard that before until we were talking. I was like, I don't even know that existed.
Yeah. So, I mean,
what do they get?
So
cranky?
I mean, I will tell you they get it a little bit easier because with ovarian function, there is this sort of abrupt drop. Right. So there's this 10, 15 year span around in your 50s, sort of like age 40, it can start and go up to 60, 65, where you're going to have fluctuating levels of hormones, but the general trend is going to go down. And then all of a sudden, you're going to have an abrupt cessation or stop of ovarian function. And when you stop ovarian function and you stop releasing eggs, your estrogen and progesterone levels go to zero. So if you measure the estrogen and progesterone levels in a postmenopausal woman's bloodstream, it will be zero.
Zero.
On the other hand, with men, the majority of testosterone is produced in the testicles. So as long as they haven't had like a chemical or surgical injury to the testicles, the testosterone level will start to decline in midlife, but very, very slowly, like a very small percentage per year. And you know that because men in their 90s can still be fertile, right? So there's still androgen or testosterone function. There is another source of testosterone or androgen release in our body, and that's our adrenal glands. It's not obviously as large a production as in men in the testicles, but you will still have some androgen release. Whereas in women, the only source of estrogen is the ovaries.
Okay. So what do men complain about that you can help them with, or can you?
I mean, I would refer a man to someone who was well-versed in that, just like I would hope that someone who wasn't well-versed in menopause would refer someone to me.
That would make the most sense. Yeah. I didn't even know that existed or it was called that. So andropause, I did not know that. So thank you for sharing that. That's great. Who shouldn't go on hormone therapy?
Yeah. So very few people that should not go on hormone therapy, but there is what we say in medicine, contraindication, meaning, again, do not pass go. These people are not to be taking hormones.
Right.
One is if you have a history of a cancer or an active cancer that is known to be estrogen responsive. And so that would be something like a uterine or endometrial cancer or specific types of breast cancer. Not every breast cancer is estrogen responsive.
Right.
So in fact, there's a huge population of breast cancer survivors who were denied menopause hormone therapy that in fact could have very safely, after discussion of risks and benefits, been on menopause hormone therapy. Any unexplained vaginal bleeding needs to be investigated before you pursue it. And with estrogen, we know that estrogen will promote the body to produce more clotting factors. That's especially true in estrogen that you take by mouth because it passes through the digestive system and tells your liver to produce more clotting factors. So you're more likely when you take oral estrogen to be at risk for blood clot or stroke. So any woman who's had a blood clot or a thrombotic stroke, meaning a stroke that was from a blood clot in the brain and not a burst blood vessel in the brain, should not take hormone therapy.
Okay. You mentioned there's the pill, there's the patch.
Yes.
And how do people know which one to take?
Yes. There's a buffet of options. A buffet of really good options. A buffet. And it really is patient dependent. They're in terms of, so the hormone that you need in menopause therapy is estrogen. That is what is going to control your hot flashes. That is what is going to make a large impact on cognitive fog and cognitive function. The bone building capacity is largely from estrogen. And in terms of genital health, it's what estrogen interacts with the skin. And we'll talk about that a little bit later with, aesthetically your skin health. Right. But it interacts with the skin to increase hydration, lubrication, elasticity. So for genital health, you need estrogen. Progesterone is included in menopause hormone therapy when people have a uterus. And that is because the uterus responds very actively to estrogen. I have this funny analogy for hormones of how I think of how they work on the uterus. So if you think of the lining of the uterus, which is what sheds when you have your period, if you think of that like a lawn, estrogen would be the fertilizer that makes the grass grow. Progesterone is the lawnmower that thins the lining of the uterus. So if you have estrogen and no progesterone, the lining is going to grow, get super thick. So you're going to have bleeding. And you're also increasing your risk for endometrial cancer because now you have this uncontrolled growth of the lining of the uterus. So you need the lawnmower in the form of progesterone to come in and keep the lining nice and thin. So anybody who has a uterus and is on hormone therapy needs to also be taking progesterone, but it can come in many different forms. So oral progesterone, which is also, the brand name is Prometrium. That has the added benefit not only of endometrial protection, but it stimulates those GABA receptors that we were talking about with sleep. And so it'll help make you sleepy. So we will treat people at night with progesterone or Prometrium. Unfortunately, the other types of progesterone, so in patch form or you can have an IUD put in that acts really locally on the uterus with progesterone. They don't have the same sleep enhancing effect.
I needed the sleep enhancing.
Yeah,
effects,
if I have a
definitely.
patient who's really struggling with sleep, then I'll say permetrium is probably the way to go, an oral progesterone. In terms of estrogen, if you, again, like I said, if you take it by mouth, there's a slight increased risk of blood clot. So I actually prescribe oral estrogen very rarely because I can't think of someone who I would want to tolerate a higher risk of clot. So it's really only people that don't tolerate the other forms, which are transdermal. So meaning a patch that you would put on your skin that slowly absorbs, or a gel or cream form of it.
Okay. Well, that's pretty easy. I'm not on any of that except for what we just talked about.
Yeah.
So that's interesting for me to know.
Yes, and the vaginal estrogen that we had talked about earlier, that is a local effect. So all of these contraindications and risk factors, they are not the same for vaginal estrogen. Almost all women can use those really, really safely.
Okay. Can we talk about how the hormones affect the skin?
Yes, absolutely. So part of our practice at North Toronto Surgical is skin health. And we know, because we see so many of these patients, is women that are perimenopause and menopausal that are losing estrogen are starting to complain about skin laxity, skin dryness, overall texture, fine lines and wrinkles. And that is because a lack of estrogen is impacting all of those factors. So there's estrogen receptors in the skin. And when you lose estrogen, now the ability to form collagen is impaired. The ability to maintain hydration in the skin is impaired. So estrogen plays a huge role in skin health and aesthetics through the midlife.
Right. And I know you give me this great laser therapy that I take. Oh my God, I look like a baby's bum when I'm done that. It's so good.
I love lasers. Oh my gosh. I mean,
if you haven't tried it, you should.
Yeah. I kind of categorize skin interventions. So you have the building blocks from the inside out. So if you're missing the building blocks and you're female, if you're missing the building block of estrogen, you can do lasers for sure. You can do Botox. You can do these interventions, but you won't be addressing the root cause of the decline.
Right.
Oral collagen is also something, I mean, the evidence is not super robust, but it doesn't appear to be harmful. And it is probably beneficial for increasing skin's hydration and elasticity. So most of my patients, I'll tell them to take 5 grams of collagen. Whether it's powder, pill, marine, bovine, vegan, the data is not clear.
Right.
So just pick which one you like and taste the best. So you've got collagen and estrogen, that's sort of from the inside out. Of course, making sure that you don't have any bad habits, like smoking will kill your skin elasticity and age you so much more quickly. So I actually really hesitate to tell people to spend thousands of dollars on interventions for their skin if they're smokers, because they just will not garner the same benefit from it.
Right.
And then metabolically, diabetes, thyroid problems, all of these will affect your skin quality. So making sure from the inside everything is good. And then you get to prevention. So prevention is huge. I would give everybody a sunscreen when they were born. Just tell them to apply liberally, no matter what your ethnicity, no matter what your sun exposure. Photo aging is the number one cause of fine lines and wrinkles. Right. So sunscreen for sure. And then there are other kind of actives that are great to use. So vitamin C serum in the morning to give you a bit of antioxidant protection is great. And then a retinoid at night. So you can have over the counter, it's called retinol. You can buy that at any pharmacy, or from your physician, you can get a prescription for a stronger retinoid like tretinoin or adaptoline. Those are a few examples. And so those ones are the topical treatments. And then once you've kind of optimized the internal, external, then if you're spending money, you're really maximizing your dollar. It's like these internal and external optimizations are your insurance policy of spending all this money. It's going to guarantee that your results are going to last when you're doing lasers and Botox. Right. And a lot of what the lasers are is they're stimulating or causing micro or controlled injury to the skin to stimulate collagen. Your skin recognizes, oh, I've had a little burn, or I've had a radio frequency injury, and it's going to send healing to that area and promote collagen and brighten and tighten your skin.
Right. Well, what I loved about your appointment is the appointment that I had with you was that you don't give me something that I don't need. You know, like you were like, oh, you don't need that. Like your skin's still good, right?
Yeah.
What about our body skin? Because I'm noticing like the elasticity in my legs and stuff like that is definitely changing. Is that because I'm not on estrogen that's happening to me?
That's a contributing factor.
Yeah.
For sure. Yeah. It's not just your face that estrogen affects. It's absolutely every area on the body. So contributing factor for sure, sun exposure or history of sun exposure. So most of us have had a lot of sun exposure on our legs and arms because we were
kids.
We were kids. And the more tanned you were, the better.
My daughters used to put the baby oil on. Oh my God.
Oh, yeah. So
not anymore.
No, now we're,
not with Alana. That's for
your
sure.
daughter is a dermatologist. She is not baby oiling.
No.
So yeah, there's so many factors that would go into it, but those are the big ones. And you can laser anywhere on the body. But the impact will not be as significant as on the face just because of the bigger surface area.
Right. Yeah. Can we just go back and talk about menopause? Like, why does it hit some women harder than it hits other women?
Mm-hmm. I mean, I see that in my clinical practice all the time, is that I will always ask, if I'm seeing someone for a routine PAP, I'll ask them about perimenopause or menopausal symptoms. And some women are like, oh yeah, I had hot flashes, but whatever, it was fine. And, like they don't want to spend any more time talking about it. And someone say it was so easy. And then other women I see who are in tears and depressed because of what's happening. So a huge amount of variability. I think genetics plays a huge component. So certainly, like if you're a mom or your sister struggled, first degree relatives, then that increases the likelihood that you'll have a rougher time. There's a few things that will definitely impact from a social standpoint. So if you have high stress, definitely, because we know that all of those hormones interact together. So your reproductive center in the brain is very close to where your cortisol is released and your system of sort of fight or flight. So, and before menopause, you know that if you were really stressed, you would stop your period, right? Like you would be late with your period because those centers are so closely combined. So certainly if you're under a lot of stress, if you already are sleeping poorly, if you use alcohol really messes with the hormonal system. So definitely some women are more predisposed, and then certain medical conditions absolutely can make you more predisposed. If you already have existing mental health or mood disorder, you can experience things significantly worse in terms of cognitive and mood symptoms. And then the last one would be really any abrupt introduction to menopause. So say you have what we call a surgical menopause. So you've gone in and you've had your ovaries removed for a medical reason. And now you are like you went from having ovarian function with estrogen to the next day having zero. Abrupt changes are going to be worse for someone than a very gradual change.
What about some myths like that there are around menopause? Is there anything that you want to address?
Oh, there's a lot of myths around menopause. I'm trying to think of one, or maybe you can tell me one that you heard or your friends have told you. But the big one is just that that menopause hormone therapy is dangerous. No one should be on it. I think that has done a huge disservice. I look at people in my mom's generation, and I just feel so sorry that they did really suffer, and they are living with the consequences now in the form of osteoporosis, bad skin health, probably increased cognitive decline.
Right. One of my friends over the holidays said to me, a gentleman, said, I watched your episode with the fitness trainer and we were talking about nutrition and menopause. He said, I remember a few years ago when you used to throw yourself in the snowbank. Thank God.
No.
I did. I would just be like, it's coming. I would just throw myself in the snowbank. So thank God we live in Canada. That I could just do that.
Yeah. Oh, it's, and it's so funny that now that I'm in the menopause world, I watch women and I can see who's having a hot flash. Like I can see that I know the preventative strategies, what people will start to do. And you can see it like, forming on the upper lip. And I'm just thinking, oh my gosh.
Well, there's strategies. One is dress in layers.
Yes.
Because it's coming off.
Yes. And I should mention, I mean, I sound like such a poster girl for menopause hormone therapy, which I am. But there are non-hormonal strategies to manage a lot of menopausal symptoms. So there's a lot of non-hormonal oral options to manage hot flashes. There's some exciting new medications that are getting approved in Canada. And there are a lot of lifestyle measures that you can do. So I've seen people with the fans around the neck. Those are great. Dressing in layers, as you said. Making sure that you're able to access air conditioning if it's the summer, or running out into the snowbank. Exactly, being able to dunk your head.
Yeah. My one friend has a fan in her purse.
Yeah,
she brings it everywhere she goes. It comes out on the table as soon as we sit.
I love it. I think those are great.
Yeah. So I guess there are some holistic avenues that people could take that don't believe in hormonal therapy. Yes. They could definitely go that route.
Absolutely. I will say, and we're kind of past this in terms of, I used to have people come in and ask me about bioidentical hormones, but what I will say is when we say bioidentical, what that means is this is the exact chemical structure of the estrogen and progesterone molecules that your ovaries are producing. We have replicated that through pharmaceuticals. So now you can have 17 beta estradiol in a regulated pharmaceutical form, and you can have your micronized progesterone that your body secretes, normally in pill form, made by a pharmaceutical company. And the reason I say that is not because I love big pharma or paid by big pharma to say that. It's that when it's a pharmaceutical company, it's regulated. So we know that what it says on the label is exactly what's in that pill. It's been tested. The lot number of all of those pills or patches or whatever they may be has been screened and is what it says it is. When you now go to compounded hormones that are done outside of the pharmaceutical industry or the food and drug industry, in Canada, we don't regulate supplements the same way that we do pharmaceutical products. There's not as strict guidelines. And so it may say this is what's in it, but when you actually have looked at it in the lab, the concentrations may vary very widely from pill to pill. So most people, I will say, you don't need to go to a compounding pharmacy to get bioidentical hormones. You can get those safely with a prescription. And so I would say that that's kind of fallen a little bit by the wayside. It was really popular 5-10 years ago to have this special compounded natural cream. But you don't need to do that anymore because there's bioidentical tested good alternatives. In terms of supplements, yes, there are supplements that will stimulate estrogen receptors, but by and large, they're very weak. So yes, it's working a little bit. Like soy products are phytoestrogens. They'll stimulate the estrogen receptors, but probably not enough to control your hot flashes. And I'm kind of like, if you want to control your symptoms and you want it to be natural, just go with bioidentical hormones at the right concentration, rather than kind of playing around with something that's not controlled or regulated. That's probably not even going to get rid of the symptoms that you want to get rid of. So.
Right. Good. Well, let's move to our rapid fire, shall we?
My favorite.
Yeah, your favorite. You've done this before.
I've done
You're
it.
almost an expert at this.
Yeah, I should be rapid firing you.
Oh, nobody's done that yet. A symptom that surprises your patients the most?
When I ask about it, anything to do with sexual activity, people are always shocked.
Oh, I was embarrassed when you asked me. You're like,
yeah. I say,
I haven't talked to anybody about this.
Yeah. Are you sexually active? Are you having intercourse?
Right.
And they're like, oh, nobody's asked me that. And in fact, I'm not, because it hurts so much. Or every time I do, I have bleeding.
Right.
Okay, we need to talk about this. This is a significant symptom. And a healthy sex life is a healthy part of being alive. And for most people, it's very, very important. And when you're not able to have a healthy sex life, it's very distressing. So if someone says to me, well, I'm not having sex, but I don't really care. My partner doesn't care either. It's okay. Like we don't need to have sex. It's not a problem. But for the most part, people will say it's quite distressing.
Right. Hope my kids don't watch this episode. But anyways, favorite midlife skin product?
Oh, I'm going to go tried and true classic. I mean, it has to be sunscreen. I mean, that's my favorite pediatric skin product. Like
I thought you were going to say oil of Olay when you said I'm going to go with classic.
Classic, yeah. Well, I mean, oil of Olay, these older products, they did have components in them that were extremely good for skin. So anything that's retaining a high amount of moisture is excellent for skin. So a nice thick cream that has ceramides or hyaluronic acid, something that's going to attract water to the skin, is great. And I really like retinoids. You have to be careful with retinoids. And I don't know if you've had a bad retinoid. Have you had a bad retinoid experience? Most people
really
have.
Bad with my nighttime care routine. We got to talk about that. I'm very bad.
Well, retinoids, you're right, are only at night. You don't wear them in the day because you don't want that interacting with sun. But most people with skin products, they'll read it and they're like, oh, I definitely want the benefits of this. So I'm going to jump into the deep end. I'm going to slather it all over my face. I'm going to use it twice a day. And they wake up in the morning and they've got redness and burns around their eyes and their mouth. And they're like, I can't tolerate a retinoid. I hate it. Retinoids, when used in the right way, will change the architecture of your skin in terms of fine lines and wrinkles and tone, pigmentation. It's the gold star.
So is this like a little dabble, do you? Is that how it is?
Absolutely.
Yeah.
And I even tell people, like, the eyes and around the lips are very sensitive to retinoids. So put a bit of Vaseline on your eyelids, under your eyes, around your lips, and then put your retinoid on. Oh. And interestingly, retinoids will penetrate anything. So it can be the last step in your routine after you've put on your moisturizer, then you can put your retinoid on. Right. And it will penetrate the moisturizer to the skin. So there's lots of tips and tricks to make it more tolerable. Even for me, like, I only use it 2 or 3 times a week because I will peel if I use it more.
Right. So, I know in the wintertime, my skin gets a bit dry. My daughter told me just after your moisturizer, put a little light layer of Vaseline on.
Yes, absolutely.
So, yeah,
Vaseline
trick.
is an excellent vehicle to increase the absorption of whatever you want. So as well, like a trick with eczema, for example, if you're using a steroid on your hand, you put the steroid on and then you put a bit of Vaseline on, it will push the steroid in so that it's more effective, as opposed to, you get it, if you're going to sleep, you rub it off on your sheets or your pillow.
Right. Yeah. Very, very good.
Yeah, lots of tips.
Hormone trend you wish would disappear.
A trend. Oh, I mean, anything that TikTok is saying that is giving you more awareness, I actually like. So period tracking is great. Symptom tracking is great. I see a lot of that. And I would actually encourage everyone who menstruates to track their cycle, because the information it can provide you is extremely helpful. So I know that's a trend that they're talking about, which I think is good. I mean, anybody who is telling you to take something and then is advertising or selling that product, I would be very suspicious of. And so I would say that is the trend I wish would go away, is people pushing supplements or products that they themselves stand to gain from financially. That should raise a red flag. Right.
Just so everybody knows too, even on Instagram now, they'll have a clip that shows that they were on Dragon's Den, for example, and that they were awarded blank, but it's a lie. They weren't. So really do your homework, because it's an absolute lie. They actually were never on Dragon's Den. So make sure if you see something on your Instagram come up as an advertisement, a sponsored ad, you make sure you do your homework. Because I got caught in that once and I thought it was going to help. And then I realized afterwards, they weren't really on there.
And there's no regulation.
No regulation, no. So do your homework. Make sure before you order anything, you're doing your reviews, you're looking at what people are saying about the product, for sure.
I mean, I heard something really interesting this morning on CBC. They were interviewing a dietitian, and she was talking about how, rightfully so, big pharma has been vilified. There are terrible stories of what big pharmaceutical companies have done for profit. I mean, oxycodone, OxyContin, Purdue, don't even get me started about it. But yes, there's a lot to answer for, but as a result of those abuses, especially in Canada, there's been extremely strict regulation on pharmaceutical companies advertising, and as well sort of wooing or influencing prescribing practices.
Right. So they can't do that anymore.
They can't do that. I'm not going on golf trips sponsored by, these pharmaceutical companies of products I prescribe. I rarely am interacting with them, in fact. And once in a while, they will have a dinner where they'll educate us about the product. But by law, they have to show us the data comparing their product to other products on the market. So really now big pharma in terms of prescribing behavior of healthcare professionals is very tightly regulated. This podcast or on the radio this morning, the dietitian was saying that the wellness industry has eclipsed big pharma profit by 3 to 4 times.
Holy.
So the wellness industry has now become this really predatory institution where they are going after people in terms of algorithms, almost always on social media, finding out what people are worried about or paranoid about, and then targeting them with a product that has not been regulated and most likely will not do anything and may actually do harm.
So can we find out if those products have been regulated? Is there a way to find that out?
Yes. I mean, you could search any Canadian government website, like the Food and Drug Administration, like Canadian equivalent. In terms of drug database in Canada, anything that has a drug identification number is rigorously tested and approved by Health Canada. If it doesn't have a drug identification number, then it has not gone through the same rigorous testing process.
You must have to do a lot of reading and a lot of research to stay on top of what's all of these tests and science.
I would say,
papers.
I mean, it's kind of enjoyable for me because I like this
you're
stuff.
a nerd.
Yeah, I'm a nerd.
Yeah.
But
that's why you're friends with my daughter.
Yeah, exactly. We're both nerds. So I would say yes.
Okay.
Yeah.
Coffee or wine? What's harder on the hormones? Don't say wine. Oh, dang.
You know
I already
what?
know what I get the hot flashes from the champagne. Oh, love it, but it drives me crazy.
I mean, full disclosure, I stopped drinking about 5 years
I
ago.
knew that. Yeah.
And I drank socially before, so I wasn't a big drinker to start, but that evidence of sort of the Mediterranean glass of red wine a night that does the heart good, we know alcohol is a toxin, and that there's no minimal safe dose. So just drink in moderation and drink to what your risk tolerance is.
Right.
And I realized, like, if I had a glass of wine, I would wake up 2 or 3 times in the night. This was in my 30s.
Yes.
I'd feel like terrible the next day. I had young kids, I had a headache or felt really sluggish. So that's my own personal story with alcohol, but I can tell you, I don't know many benefits of alcohol. Mm-hmm. And especially around the menopause transition, it will worsen symptoms.
Right. And coffee, does it have benefits? Because they say that it does.
Yeah. I mean, coffee is a little less cut and dry. We know that coffee in small amounts likely is beneficial, but again, you can have too much of a
three coffees a day.
I know. Well, yeah, I didn't give up coffee, so too much of a good thing is also not great.
Yes.
Like it does impact your sleep. And so if you, and we all know this, I'm not giving you a medical breakthrough here, but if you have it too late in the day, obviously, then it's not allowing your body to have the signal to start to wind down.
Right. I can't have a coffee after 2:30.
Yeah.
Forget it. Hot girl walk or a nap on the couch? Which one's better for you?
Okay. So you're asking me exercise or sleep. Both are so beneficial. I would say sleep takes the cake. So if you are sleep deprived, I will always recommend sleep, like sleep hygiene above everything.
Right.
Right. But it kind of depends. Like if you've had a not so great sleep, but it's like 4:00 in the afternoon, I probably wouldn't take a nap just so that then you could have a good sleep that night.
Right.
And we know that a quick burst of exercise is really, really good for brain function. So can I go half and half? Can I say like a 20-minute nap and then a brisk walk around the block?
Yeah, I think so.
Yeah.
I'm probably one of the people that I know that I can have a 2-minute nap. I can drool,
that's
be gone for
amazing.
2 minutes and get up and everybody says, I thought you just went for a nap. I'm like, I already had one. And
That's
they're
a
like,
huge skill.
Yeah. It's a good skill. My daughters both cannot do that. They're like,
Yeah.
if they go for a nap, it's like a couple of hours
Yeah.
and they still feel
And you
terrible
wake up
when they
feeling
wake up.
terrible. Yeah, there is that window that sleep experts have looked at it.
Yeah.
That sort of the 20-minute mark is magic, and more than that's probably not going to make you feel better.
I'm the 2-minute napper. That's it.
very
I
good.
can put my head down anywhere and just have a little nap.
And even like I'll just go into a little side note on mindfulness or meditation, but with meditation, your brainwaves will act very similarly to how you are acting in certain stages of sleep. So even if you take like a 10-minute break of just deep breathing, you wake, like you come back and you feel more refreshed. So you don't necessarily have to knock off and go to sleep.
Right.
There's probably benefits of just taking a break and taking a few moments. Yeah.
Good. If menopause were a weather forecast, what would it say?
Oh, I mean, something to do with heat waves for sure. I would say like heat waves with a chance of really stormy weather.
Right. Possible rain because we're sweating.
Yeah. But the clouds will open at some point. And some of you, that's going to be 6 months, and some of you, that's going to be 10 years.
Right.
So, yeah.
I think I was about 5 years, because I think I'm on the other side now. I am sleeping. My hot flashes are few and far between.
Yeah.
If I do drink alcohol, I do definitely get hotter for sure.
For it.
Yeah, I pay for it for sure.
Yeah.
Yeah. Well, that was amazing.
So fun.
Yeah. Tell everybody where they can find you.
Okay. I accept patients without referrals. If you have a referral from your family doctor or walk-in, wonderful, great. You can have them fax our office, and our fax number's on our website, northtorontosurgical.com. Or you can visit the contact us link on our website and email our office. And my amazing assistant, Gabby, will get back to you and book you in for an appointment.
Right. So they can come to you for an appointment regarding menopause, or they can come about skin health.
Yes, contraception.
Yeah, contraception. Yeah. Thank you.
You're so welcome.
If this conversation helped you feel seen or supported, share this episode with another woman who could use the same reassurance. You can find all of Dr. Dupuis' information in the show notes. Thank you for listening. Until next time, take care of yourself, ask the questions that matter, and know that your health is worth advocating for.